Oops. All right. So I started to tell these guys in here, everybody online, you're going to get it now. So Jamie made it very, very clear to everybody that with EMS testing, you're not able to see your questions that you did and or got wrong or got right for that matter. It's just the way that it's set up. It's set up that way because if you was able to see the questions, you guys are going to study the questions. You're not going to study the material that you're getting wrong. And that's not going to do you any good for registry. What you need to do is you need to go back through, look at the comprehensive breakdown that it gives you at the end, and study from that. Whether it's pharmacology, whether it's respiratory, whether it's the blood flow through the heart, whatever it is, that's what you need to study off of. You don't need to study off the questions that you got wrong. The other thing is you cannot copy and paste questions off of EMS testing. You guys were told that when we started class. You were told that at the beginning of every test, you have to hit I acknowledge. It's the second that you highlight and try to copy a question, all the instructors get an email and you get locked out of your account. It's copyrighted that way on their site for a reason. You don't need to study the questions. You need to study the material that you're getting wrong. Some of you sent the messages, made the comments. You didn't know that we had a test today. It's on Google Classroom. When Chris talked to you guys, he told you after we took the test, you had the option to either be taught the other 2 chapters, or that could be self-study, or we could do a review. It's on you guys if you don't pay attention to what's on Classroom and what you're told multiple times. The other thing is, now I have to pull this back up. On your guys' Google Classroom, there is a link under classwork. Pull mine up and I'll show you. Oh, you bastard. Under classwork, under Zoom link, assessment practice signups. You guys look different on there. Under Zoom assessment practice sign up, you guys can go on there to sign up for the available times and dates to practice assessments over Zoom with one of the instructors. It is on you to do it. If you guys are struggling, I highly recommend you do it. I was just telling everybody that's here that is in person. This is an adult class, and you guys are responsible for how you do in class. The other thing that I'm going to tell everybody right now is for those who are failing tests repeatedly or bombing certain subjects, if you don't feel that it's covered good enough when we do lecture, you guys need to be adults and you need to speak up at the end of the lecture when all of your instructors say comments, questions, concerns. You're able to send private messages on Zoom if you don't want to be heard by everybody, or you're able to message your instructors. You're able to ask questions in private on Google Classroom, or you have the ability to send an email. I can tell you right now, all of your classmates get the same material that you guys do. And there are people that are continuously either getting very close to passing and doing test corrections and then doing better. And there are people that are flat out passing the test, and it shows that they are at home studying, taking time, reviewing material, doing the EMS test prep. I'm going to pick on you, Bobby. How much do you study at home? If you don't understand something, though, do you go home and study it? Or ask questions? And that's the thing. It's an adult class and we all have lives. I get that. But you have to put in the time. If you don't put in the time, it's your fault. And you guys are trying to take a class to get into a field where it's somebody's life that you're dealing with. It's not someone's food order. It's not someone's drink order. It's someone's life. And if you can't be an adult enough to realize that, then that's on you. I have zero sympathy for those who don't put in the time or the effort and that don't ask the questions. I can tell you, I know Zach has asked questions, Bobby has asked questions, you've asked questions, you've asked questions, you guys have asked, almost everyone has asked questions at some point, but not consistently. If you struggle on a subject after you study it, ask questions after we do lectures, ask questions when we do labs, ask questions in general, email them, text them, classroom them, ask each other, reread it in the book, whatever it takes. But some of you aren't doing that. Some of you also are choosing not to do test corrections, and there's zero excuse for that. Absolutely none. The biggest thing with test corrections, and I'll tell you guys this right now, as someone who's taken a basic class, advanced class, and a medic class, and helps teach, and I help out at other places, a lot of other places don't do test corrections. You get a test retake, and if you don't pass that one, usually you're out. Eastern Gateway, it's real simple. You maintain a certain grade point average or you're out, and you have to pass all your tests the whole way through. Each individual test you have to pass, either the first time or on a retest, and if you don't, you're out. We don't do that because we do test corrections. If you don't do the test corrections, how are you supposed to learn from what you got wrong? If you don't do that, that's on you. Again, no sympathy. I've done it. I've worked full time, still manage family time and everything else, and went to medic school. Did an accelerated class. I did my medic in 9 months. So your guys' class is what, 4 months? 4 to 5 months, 4.5, whatever it is. I did a whole paramedic class in 9 months. So under twice the amount of time as you guys, 5 times the amount of material, and had to pass. I didn't have test corrections. My homework was due when we walked into class. You miss 3 homeworks, you're out. You fail a test, don't pass 3 tests, you're out. So it's that simple. So for those of you that do not wish to put in the time or the effort or the energy, it's on you. And I believe you guys were told that at the beginning. It's on you. Your instructors cannot care more than you do. Other than that, again, you have questions or there is something that you simply do not understand, write it down and we will start to go over it. For now, though, we're going to start this whole Kahoot thing. We're going to go off of prior exam questions that the majority of you guys had an issue with. We'll go through them in depth. For those of you that's online, I told everybody in person, if at the end of class, if we run over on time and there's something that you need to know, you're welcome to stay on and ask and we'll go over it. Or send an email, a text message, whatever. You all have my phone number. I'll be more than happy to answer. Getting closer. Okay. Just waiting on 2 moths. Okay. Oh, so fancy. What is the name of the process that results in the movement of gases, oxygen and carbon dioxide, across cellular membranes in the lungs and the peripheral tissues? So as we go through, we will explain all 4 of these. Respiration refers to the process of moving oxygen and carbon dioxide across the membranes into and out of the alveoli, capillaries, and the cells. So that's respiration. Oxygenation is the form of respiration in which oxygen molecules move across a membrane from an area of high oxygen concentration to an area of low oxygen concentration. Cells are oxygenated when the oxygen moves out of the blood in the vessel and into the cell where it is used in metabolism. Oh, ventilation. Ventilation is a mechanical process by which air is moved into and out of the lungs. Ventilation is primarily based on changes in pressure inside the chest that causes air to flow into and out of the lungs. That positive, negative pressure that we talked about before. And perfusion is the delivery of blood, oxygen, and metabolic substrates to and from the tissues and cells of the body. Does that all make more sense now? Okay. Anybody online, any questions? Comments, concerns? Okay. Quiz time. 23-year-old male patient has been shot with a rifle by an assailant standing in front of him. The bullet entered the victim's chest just above the left nipple and exited his body laterally left of his 4th lumbar vertebrae. Proper documentation of this injury would include. Okay, that went way too fast. That went way, way too fast. Oh, seriously, you're not going to want me to do it? All right, I cannot change the timer, guys. So with him being shot in the front is what? Anterior. So you have an entry wound to the anterior thorax being what? Yes. So exit wound to the posterior torso. What's torso? Yeah. So obviously no. Entry wound to the abdomen, no. Or exit wound to the posterior thorax. Yeah, technically not incorrect, but it's technically the cervical area. So entry wound to the anterior thorax is just the most right answer you could possibly have. Yeah. Biggest thing, but you can't, so what they're saying in here, guys, is finding the exit wound is important. The biggest thing with gunshot wounds and working in the city of Youngstown, I can tell you this. You cannot tell what's an entrance and an exit wound every time. So the biggest thing is, do I have 2 holes? Do I have 1 hole? Where are they? Do we document each and every one of them? Yes. But the biggest thing is, I have what looks like an entrance and exit wound. Because I can tell you, I had a shooting, I had 3 holes, 2 in the front, 1 in the back. The entry was in the back, the bullet broke off and exited through the front. So I had 2 exits for 1 entry. Anybody have any questions? I know that went way too freaking fast. I will try to adjust the timer for the next one, so bear with me for this one. Inspiration occurs when diaphragm rises and moves downward. So let's see. Pretty sure there's going to be an explanation on this. During inspiration, the diaphragm and the intercostal muscles contract, increasing the size of the thoracic cavity. The diaphragm moves slightly downward, flaring the lower portion of the rib cage, which moves upward and outward. This creates negative pressure in the chest, which causes air to flow into the lungs. Think of it like a vacuum. When you turn a vacuum on, inside of that vacuum is a negative pressure. It's pulling air in. So a negative pressure inside your thoracic cavity is going to pull air inward. Positive pressure is going to push it out. So when your diaphragm and your intercostal muscles contract, they're pulling together. As if you can think of contraction as pulling, those muscles and the diaphragm are pulling inward, which is going to pull air inward. That's inspiration. I'm sure there's 3 more to go through. Exhalation is when the diaphragm and your intercostal muscles relax, decreasing the size of your thoracic cavity. The diaphragm moves upward and the ribs move downward and inward, creating a positive pressure within the thorax and causing the air to flow outward. So if you think of it, when we breathe out, that's a relaxation. Our body is relaxing, it's pushing the air that we have inside our cavity out. Okay. What is the primary function of the left atrium? It receives blood from the pulmonary veins. So, how many of you remember or have heard the TPMA? So your valves of the heart. So when I went to basic school, we was taught toilet paper my ass, TPMA, tricuspid pulmonary mitral and aortic valve. And we're going to get into that when we get to the blood flow through the heart. But if you think of the heart and its 4 chambers, what sits on top, the atrium or the ventricle? So your atrium is what pulls in or brings in the oxygenated blood from the body, well, from the lungs, I'm sorry. It brings in oxygenated blood from the lungs. It goes from the atrium down into the ventricle, from the left ventricle out to the body. So if we think of the position, the left ventricle is the big muscle portion of the heart. The reason that is that has the biggest job. Its job is to push all that oxygenated blood out through the whole body. So its job is, your left atrium's job is, it receives the blood from your pulmonary veins, empties it into the left ventricle through the mitral valve, and it exits down from the mitral valve into the left ventricle, from the left ventricle out the aortic valve to the body. Why I still remember that, I don't have no freaking clue. Which portion of the heart is in failure when it can no longer effectively pump blood to the lungs? The right ventricle. So again, if we think of the position of the heart where it sits, our atriums sit on top of our ventricles. Our ventricles is what usually is what's going to pump blood out through, to somewhere. So once our left ventricle pumps the oxygenated blood out to the body, it circulates back through the body. Well, it has to go through the whole process again. So that deoxygenated blood is going to go into the right atrium, from the right atrium to the left to the right ventricle. Then it's going to go from the right ventricle to the lungs to pick up oxygen, to go back up through, to dump into the left atrium, to dump down into the left ventricle, to go out to the body. Make more sense? If I could draw for everybody, I would, because I'm a freaking fantastic artist. You would think I'm Bob Ross with this. So yeah, yes, I need a wig though, because I can't grow it. So again, if everybody just wants to, if you take a piece of paper and you draw a circle and you put, a line down and a line across, and you have your 4 boxes, and you do left atrium on the top, left ventricle underneath of it, right atrium, right ventricle, and you look at it that way, as we go through this, you're going to be able to kind of draw a picture of which way the blood's going to flow. And that it'll all make more sense. But your right ventricle is what receives the blood from the right atrium. That is, yes, my man, you paid attention. Yes. So like he was just saying, you guys online couldn't hear it, I'm going to sum it up. So the right atrium receives your deoxygenated blood. It's what flows down through the tricuspid valve into the right ventricle to go out through the pulmonary arteries. It's going to carry it through the lungs. It's going to pick up its oxygen. From there, it's going to go over to the left atrium, go down through. Then it's going to go from the left atrium down through the mitral valve into the right ventricle, or the left ventricle. From the left ventricle out the aortic valve to the body to deliver the oxygenated blood. Again, drawing that circle with the lines, we're going to be able to paint a beautiful freaking picture. The left side of the patient's heart is in severe failure, causing blood to back up behind it. Which sign or symptom are you most likely going to observe first? You're going to get crackles in the lungs, and here's why. Like I just said, if we follow that drop of blood in our head, if the left ventricle, let's just say the left side of the heart's not working appropriately, okay? So the left ventricle doesn't have the strength to pump the blood out to the body, right? That's what it's pumping the oxygenated blood out. Well, it gets it from the left atrium. So the left ventricle is not doing its job and the left atrium is not doing its job. That oxygenated blood comes from where? Correct. So the oxygenated blood that's getting pumped to the heart is coming from the lungs. If the heart can't pump it back out correctly, then it's going to backflow into the lungs, and that's where we get our crackles. Swelling in the feet is going to be if you have a right-sided heart failure patient, because then the blood's going to back up to the place that it came from, which is from the body. Our left side sends it it takes it from the lungs to the body. The right side gets it from the body to the lungs. Yes. If you guys think of it this way, match your L's. Left side lungs. That's how I always remember it. L and L, left side lungs, right side is going to be the body. The patient is experiencing the backup of blood and fluid in her lung tissue. Failure of which of the heart's valves is most likely responsible for this condition? Remember, TPMA. Your mitral valve is also called, let's break this down. Hang on here. I'm going to show you guys a picture and it's going to make everybody's life a little bit easier. Stand by. Try to find a good one for you guys. All right, here we go. Maybe. That's kind of a piss poor one. Well, no. All right, let me pull this back up as well, and I can show you guys. I can put them side by side. Okay. All right, never mind, it's not going to work. So if we look, your bicuspid valve, and this is where MedTerm comes back into play. Your bicuspid valve is also going to be this valve right here, which is your mitral valve. So we're getting the back up to the lungs, right? So what do valves do? Most valves are one-way valves, right? So blood's supposed to flow through the mitral or bicuspid valve into the left ventricle and then out, right? So if this valve is bad, bicuspid valve or mitral valve is bad, it's going to let blood flow back through into the left atrium, back out that pulmonic valve, and back into the lungs. Again, MedTerm is a bitch, and I get that. But think of it, bicuspid and mitral valve are the same valve. You're going to see it either way on a test. You can literally have two questions back to back on registry. One can say bicuspid, one can say mitral. Because they are both the same thing. They just have two different names. Does that make any more sense for anybody? Yes? Okay. All right. So get rid of the freaking AHA picture here because it sucks. Oh, here we go. All right. So if you think of it, I'm not going to use all these ones and numbers. If you think of it, the left side of our heart, so we're getting the oxygenated blood in through here, down through the mitral or bicuspid valve, into the left ventricle and out. But, and with the last question, if you stop and think about it, valves are supposed to be one way. So they're supposed to open, let blood flow through, and close. When they're closed, nothing's supposed to flow back through them. Well, when that valve goes bad and it just stays open, it's going to let that blood flow go back up through the heart and back out to where it came from. So it's going to put that blood back into the lungs. So again, we get the deoxygenated blood in, it goes to the right ventricle, gets pumped out the right ventricle, goes and picks up some oxygen in the lungs, then comes back up through, dumps into the left atrium, from the left atrium to the left ventricle, from the left ventricle to the body. Again, so TPMA, tricuspid pulmonary mitral aortic. However, mitral, bicuspid, same damn thing. It's stupid, I know. Welcome to the medical field. During your secondary survey of a patient who is unresponsive, you obtain a blood glucose and find it to be 658. So what part of the endocrine system will this disturbance best pertain to? Endocrine sucks. So if you guys get a question like this on a test, I'm just going to teach you this right now. You can study endocrine, and there is 5 different terms that will all sound alike. There'll be 3 different meanings for something. When you can stop and think of it, hypothyroid, parathyroid, and thyroid, you can cross out, right? The islets of the Langhorne. Let's just give you the explanation, because my explanation is going to screw you guys all up. So they're in the pancreas, and this is kind of one of those things where you guys had to pay attention when you did endocrine. Is it a little in depth? Yes. And is it very confusing? Yes. But it all makes sense when you put it together. And I know Jamie hounds on this because endocrine is one of her big things. But the islets are which is what's in the pancreas, and it's what makes insulin, which allows glucose to enter the cells and also produce glucagon, a hormone that raises the glucose level in the blood. If the pancreas ceases to the production of insulin, as in type 2 diabetics, then the blood sugar level can rise dangerously high. Remember, insulin production is what helps manage high blood sugars. That's why usually your type 2 diabetics at some point become insulin dependent. That's why one of the questions we usually ask them is, are you insulin dependent? But if you guys stop and think about this for a second, how many times did you ever hear when you get in your lecture, could you link thyroid and hyperglycemia together? So to me, in my brain, the way that I test, I just instantly cross those 3 out. But your islets and Langhans are what is in the pancreas, and that is what allows our body to do the production of insulin and glycogen and all that. Your thyroid glands are what regulates metabolism, growth, and development. The parathyroid gland is what produces the hormone that is necessary for metabolism of calcium and phosphorus in the bones. And the hypothyroid does not exist. You can have hypothyroidism, which is a disease where your thyroid does not function properly. That's usually when we take Synthroid to help boost our thyroid's function up. But the thyroid gland is what regulates metabolism, growth, and development. The parathyroid is what produces the hormone that is necessary for the metabolism of calcium and phosphorus in the bones. So it's 2 completely different areas between thyroid and endocrine. Oh my God. Pressure and volume of blood in the left ventricle at the end of diastole is called what? So preload is the pressure that is generated in the left ventricle at the end of diastole, which is the resting phase of the cardiac cycle. So med term 101, you'll want to write this down since you just got back. So again, preload is the pressure that is generated in the left ventricle at the end of diastole. So remember, diastole is the resting phase of the cardiac cycle. Preload pressure is created by the volume of blood in the left ventricle at the end of that cycle. The available venous volume, which determines the volume of blood in the ventricle, consequently plays a major role in determining preload. So diastole is the resting phase of the cardiac cycle. What is left in the left ventricle after that period is your preload. Yeah, die, rest. There you go. If you remember die as rest, you can put the two together. Systolic blood pressure is determined by multiplying the cardiac output by the systemic vascular resistance, and afterload pertains to the resistance the left ventricle has to overcome to open the aortic valve. Cardiology sucks, in case anybody was wondering. Answer the following. A patient with a low blood sugar is unresponsive with snoring respiration. His breathing is labored, his pulse is rapid and weak. Examination of the skin reveals it to be cool and diaphoretic. The partner informs you of the following: vital signs, pulse 120, respirations 18. Okay, this is retarded because this is not going to work. I'm glad you guys got through that. Honestly, yes. I'll go back to that in a second. Fusion is best described as what? Perfusion is the delivery of essential products and nutrients to the cell for its use. During the relaxation of the diaphragm and the intercostal muscles, what happens to the interthoracic size and pressure? The size decreases and the pressure increases. Yes. Yes. I'm going to attempt to fix that. What is the primary stimulus to breathe in human beings without pulmonary disease? What makes us breathe? Causes us to take a breath inward and outward. If we have no pulmonary deficiency, the rise of CO2 in our body is what makes us breathe. When you breathe off of a hypoxic drive, so our COPD patients, when their SpO2 falls is when they breathe. So somebody without a pulmonary deficiency is going to breathe, their brain is going to make them breathe whenever the CO2 level within their body rises. For a patient who relies on the hypoxic drive to breathe, the respiratory rate will increase when, just gave you this answer. Oh, no, let me down. Don't let me down. when our O2 level decreases. So COPD patients who breathe on a hypoxic drive, so those with a pulmonary deficiency, breathe when their SpO2 drops.
One of the answers is CO2 levels taking over. So in a patient that's a 9-year-old that's having respiratory issues, their facility is doing too much.
Oh, there's a chance.
Okay. I wasn't sure, like answering the question.
Yeah. Again, so any pulmonary deficiency. So when we breathe off of a hypoxic drive, think of that right there, hypoxic, low SpO2. Normal people without a hypoxic drive or that have no pulmonary deficiency, we're going to breathe when our SpO2 drops or when our CO2 increases. Good God, I read that back. So when our CO2 increases, that's what triggers us to breathe because we need to breathe that carbon dioxide off. So our respiratory rate will increase and we'll breathe that off. For COPD patients, their SpO2 starts to drop. And that's what's going to trigger their brain, hey, I need to breathe. That's why they always tell you, triggering a COPD patient to 100% is not always the best treatment. A patient's SpO2 increased from 89 to 95 after he received a bronchodilating drug for his asthma. Where did the patient's problem most likely originate? The ventilation portion of the VQ ratio. So perfusion is obviously not the issue. Cellular perfusion is really not the issue either, because if you think about it, when our cells are perfusing, what's happening in the body? Our body's delivering everything, right? Minute volume, no. The ventilation portion, so think about it. We gave them a bronchodilating drug, right? So we open their bronchioles up. We're allowing them to breathe better. So we're having a constriction on our breathing. Our ventilation is obscured. Our ventilation is reduced. Given a bronchodilator, allowing them to breathe better, opening their bronchioles up is going to increase ventilations. Make sense? Well, it may not increase ventilation, but it's going to allow for better ventilation. It's going to allow us to take a full ventilation. It's going to allow for us to get a full breath of air in and out. We're not air trapping, so we're not trapping that CO2 inside of our body. Shit. Which situation would most likely cause a patient to have a simple episode of a syncope, aka fainting? The parasympathetic stimulation. So sudden release of norepinephrine, no. Increase in systemic vascular resistance, no. Activation of the sympathetic nervous system, no. Why is it the parasympathetic? Someone in here knows this, and I know that. Or someone online. We're going to have class participation today. Okay, I understand that. What was you saying? And that's a big problem. So did anybody in here answer correctly? What made you answer it? So Bobby's exactly right. So our parasympathetic nervous system is what stimulates our vagus nerve. When we vagal out, we have syncopal episodes. So that vagus nerve is activated by our parasympathetic response. Get a gold star. What role do chemoreceptors in the body play in regulation of blood pressure? It can stimulate the sympathetic nervous system if CO2 levels rise. Anyone here got it right? Anybody? What made you answer it? So like he's saying, if you stop if okay. So yes, if you can relate it to something you've gone through. So he was saying, if you think of like your baroreceptors as a monitoring device for our body, when our right. So like he's saying, he's comparing them to like a barometer. So we're either doing good or we're doing bad. So as our chemoreceptors are monitoring our body, it can stimulate the sympathetic nervous system if our CO2's level rises. Because if you think about it, your sympathetic nervous system is what's going to tell you, hey, dumbass, you need to breathe more. You need to breathe some of the CO2 off. So we're going to increase respirations and we're going to blow off some of the CO2. So if you think of that, like he said, your chemoreceptors are that of something that's going to monitor. Well, when they monitor, they can stimulate the sympathetic nervous system to make us breathe more if our CO2 levels rise. So it also can slow our respirations down if we breathe too much CO2 off, because we need that perfect, mix of the two. You've been called for a patient who's overdosed on drugs and alcohol. The patient is responsive to painful stimuli, has shallow respirations, and is breathing 8 times per minute, but exhibits no cyanosis. What is the priority treatment? Word of God, if we get this wrong. All right, 12 to 20. Was that? All right. Don't get discouraged because the timer sucks. We're going to try to shut this off next time. So, well, adjust it, I should say. Inadequate breathing is anything less than 12 and technically more than 20. We have shallow respirations. Technically, I think that's at agonal, right? Yes. So you've been called for a patient who's overdosed on drugs and alcohol. The patient only responds to pain, has shallow respiration, and is breathing 8 times a minute, but exhibits no cyanosis. What is our primary treatment? So we're inadequately breathing. So we're breathing less than 12 times a minute with shallow respirations. So we're not going to be bringing enough oxygen into our body, even whether we're exhibiting signs of cyanosis or not. What happens when we inadequately breathe? We breathe for them. You have a patient that's inadequately breathing, we breathe for them every time. Right. So, yes. So that is the biggest thing I want you guys to take away from this, even though the timer screwed it up. Anytime we have inadequate respirations, we breathe for our patient. Remember, adequate is described as 12 to 20 times per minute with normal inhalation. We're not shallow respirations. 8 times of shallow respirations, our body is not going to be able to perfuse correctly because we're not going to bring in enough oxygen. So we breathe for those patients. Huh? That was. These are literally test questions and answers. 21-year-old female has overdosed on an unknown drug. She has snoring, respirations, and intact gag reflex. She has a weak respiratory effort and slightly cyanotic. Given these assessment findings, your care should include. All right, timer sucks. I get it. 21-year-old female patient has overdosed on an unknown drug. We're going to address this after I read this question too. She has snoring, respirations, and an intact gag reflex. She has a weak respiratory effort and is slightly cyanotic. Given these findings, your care should include. So if we have a gag reflex, we do not do OPAs. So the other thing with airway adjuncts, we overdose, correct? That is a reversible cause. Anytime we have a possible reversible cause, we go with an NPA over an OPA. Because as we reverse that cause, that OPA can cause that patient to gag and aspirate. NPAs, no, they're just not comfortable when they get removed. So with that, transport the patient in the lateral recumbent position. Well, we're not doing anything for their oxygenation. Placement of an OPA, that's contraindicated because we still have a gag reflex. Oxygen via non-rebreather. Well, why is that contraindicated? Let's see. Just snoring, respirations, and a gag reflex and a weak respiratory effort. So snoring, respirations, what's that tell you about the airway? It's not a patent airway. So we're going to insert that MPA and we're going to bagging this patient. So should be BMB with that? Absolutely. But we're going to insert the MPA, bag our patient because we have a non-patent airway. Jesus Christ. Okay, you're set. Just if you answer it, you answer it. If not, we're going to go over because it's damn timer. Good job for those that you freaking sped, Red. All right. You're assessing a young male patient who is ejected from an automobile at a high rate of speed. He responds to painful stimuli by posturing and displays agonal breathing. His pulse is weak and thready, and his skin is cool and diaphoretic. When addressing this patient's airway and breathing, the EMT must immediately. Why are we going to use the jaw thrust maneuver? Okay. Why would we not immobilize the patient, then ventilate? ABCs. And yes, Caitlin, you are correct. The jaw thrust is the trauma one. Open the airway using a head tilt chin lift. I would smack somebody. And administer O2 at 15 liters per minute via non-breather. Are we doing anything for the airway positioning? Okay. Yeah, we're gonna figure this timer thing out. Your paramedic partner is applied continuous, so we put the patient on CPAP. To a patient in respiratory distress from CHF. As an EMT, you realize that this treatment should benefit the patient by. Why? What is CPAP, first of all? What does CPAP stand for? Yeah. So CPAP is continuous positive airway pressure. So with CPAP, you're getting that continuous positive pressure clear down to the alveoli, which is what's going to keep our alveoli open. That continuous pressure, then while we're keeping our alveoli open and forcing oxygen in there, also that pressure, if you stop and think about it, is pressure is going to displace the fluid that's in the lungs and push it back into the interstitial space so that we can breathe. So it's going to displace the fluid in the alveoli back into the bloodstream. Well, it's not going to collapse a portion of the diaphragm. Doesn't cause the diaphragm to relax during inspiration. And removing air from the lungs during exhalation, surely in the hell is not CPAP. So either A, we know what CPAP is, or we're just looking at the most right answer. But again, CPAP is continuous positive airway pressure. So we're getting that constant pressure down to the alveoli sacs, which is going to keep them open, which is going to help our body oxygenate. Okay. Yes, yes, yes. Congratulations. Good job. Yeah. Okay, leave this one. Come on, internet. Okay, everybody take like 5 minutes.
We're talking. Oh my God, but then it's like. Like you just completely.
We'll. I'm actually gonna mention that online. All right, so for everybody that's online as well, listen up. So a couple people in here was saying that they are nervous about the final. If you are a bad test taker or you get test anxiety or you're nervous, I'm going to tell you the best thing that anybody can do in this class is be on EMS testing as much as you possibly can between now and Wednesday.
Don't leave your thumb.
Yeah, don't leave your thumb on the thing, don't do, but I'm gonna, don't be copying and pasting, because I promise that I will end up losing my shit. Yeah, you can take the test 8,000 times, and I recommend it. Take it as. Yeah, the way they're on there, you can go back through. Yeah, you can keep going through. If it doesn't let you go back through, shoot somebody a text message. We'll get them back open again. Instead of watching TikTok when you go to the bathroom, do EMS testing. I promise you hammer through these tests, and I promise you it's easier when you go take a test. The thing of it is the more you practice something and the more you do something, the more of a repetitive motion you do, the better it gets, the easier it gets. What I did for medic school, I did both of those. I did subjects, I did the whole thing, I did the run throughs as many times as you can. It will help you. Oh, you son of a guns.
Stupid money.
Yes. Well, see, I covered my ass on this one. So I parlayed it. And I bet, because I like to do first half, second half winners. So I did do, because Dallas is not a first half team. They never have been. I did Buccaneers win in first half, Dallas second half. Two. And Dallas just scored again. You miserable bums. Two, 4, 6, 8, 10, 12. Technically waiting on one, I believe. Okay, there we go. All right, what else, gentlemen? When assessing a patient's pulse, you note that it is irregular. That's my fault. I also quit reading, but I'm in the middle of having a back spasm. If you start to count a patient's pulse rate, yeah. If we're having technological issues, I'm going to go over these. I'm going to try to get through some of them so I can get to some of your guys' questions. I'm going to ask Jamie if we can set that up to do it that way. Okay, then yes, then you can go in and do these. When we count, whenever we are taking a pulse and we have an irregularity, the best thing to do is count that pulse for 60 seconds for a minute. That way you get your true minute count. You've been directed to a car that struck another vehicle at a moderate rate of speed. You noted deformity and scarring of the windshield on the driver's side. What should you do to determine whether the deformity of the windshield was caused by the driver hitting his head or the airbags? Just because airbags are deployed does not mean that we won't hit our head on the windshield. 9 times out of 10, what will help that is the airbags and seatbelt, but assess the patient's head. Assessing your patient is always going to tell you the most about your patient. I'm gonna throw something at you. Oh my God, just hang on, because if you guys can get this, then.
Can't see the letters.
All right. Kudos to you speed readers. A conscious and alert 64-year-old female patient complains of chest pain and mild shortness of breath. She appears to have no difficulty speaking and states that her pain suddenly started about 2 hours ago. Her daughter on scene advises you there is a history of blood clots in the lungs of the family, and she is scared and would like her mother to be evaluated. Which of these steps should you take first? A, B, C, airway, breathing, circulation. So perform a secondary assessment. No. Place the patient on the stretcher for transport. No. Consider administering oxygen to the patient. Maybe, once we do an assessment. Or determine the adequacy of the patient's breathing. Bingo, Yahtzee, Jenga, Parcheesi. You always are going to determine how well they're breathing. Open patent airway. Breathing. Adequate, inadequate. Equal chest rise and fall. All the good stuff that goes along with it. An emergency medical responder informs you that a 59-year-old female patient is responsive to verbal stimuli. What would be the most accurate representation of this status? That answer is pretty clear cut, right? Bingo, Yahtzee, Jenga, Parcheesi. So if she's alert to verbal stimuli, she's going to at least open her eyes when you talk. So A is wrong. Her eyes are closed, but will open them if asked. Yes, because verbal stimuli, you're asking her to do something. She's able to answer all questions appropriately when asked. That is A and O. That's alert and oriented. And she's awake but having difficulty telling you her name and where she is. Again, A and O question. Assessment of the patient's neck reveals that the trachea is deviated to the left. Based on the assessment finding, the EMT should suspect an injury located in the patient's chest, head, cervical spine, or abdomen. The chest, why? So, you noted that the trachea is deviated to the left. So more than likely, we have a tension pneumo of the right because it's pushing everything to the left. So with that, we have a chest injury. God awful. Oh, Jesus. An unresponsive 54-year-old male patient was found by his family in bed. They state that he has not been feeling well and complained of chest pain before going to bed approximately 1 hour ago. According to the family, he has no prior medical history and does not take any medications. Primary assessment reveals no life-threatening conditions. When performing the secondary assessment of this patient, the EMT should. An unresponsive 54-year-old male patient was found by his family in bed. The patient states that he has not been feeling well. Wait a second. This is a bad question. He's unresponsive. Oh, no, they state he has not been feeling well. Never mind, John needs to learn how to read. Hooked on phonics, somebody buy it for me. An unresponsive 54-year-old male patient was found by his family in bed. They state that he has not been feeling well and complained of chest pain before going to bed approximately 1 hour ago. According to the family, he has no prior medical history and does not take any medications. The primary assessment reveals no life-threatening injuries, so that means that we have intact ABCs. When performing the secondary assessment of the patient, the EMT should focus on the examination of the chest. No, we're not going to contact the doctor. Determine whether the chest pain still exists. We can't do that on an unresponsive patient. Or start by examining the head. How do we examine a patient? Head to toe. Correct, Munde.
I just looked for it. That's one.
I like the theory. These damn cat. For the record, all you people, the cat. Well, hang on. En route to the hospital, you start the reassessment of a 22-year-old trauma patient. You should begin this assessment by repeating the primary assessment, assessing for additional injuries, checking all interventions, or rechecking vital signs. Repeating the primary assessment. We are starting our reassessment. Yes, it's a big circle. It continues round and round and round. Yes. However, for all you football fans, the damn Cowboys are winning this first half, which is not good. They needed to win the second. Go home. Why do you talk to your husband? He needs off the fire department. They are America's team. The underlying pathophysiology of distributive shock is I can tell you which two it's not if you guys want a hint. Pathophysiology of distributive shock. So loss of blood volume, hypovolemic, poor fluid intake, hypovolemic really, or dehydration. Damaged heart with poor contractility. Yeah, heart does distribute, but dilation of the blood vessels. Why would that be it? Think about it. If pipes are normally yay big, and then they go to yay big, how can you distribute the same? When paramedics administer IV fluid as a treatment for hemorrhagic shock, the fluids will not be. Think about something, and this is a little above your guys' realm of scope. What carries oxygen? What specifically in the blood? Hemoglobin. I don't carry hemoglobin in my normal saline. So can saline increase the blood pressure? Yeah. Is it going to really affect the metabolism? No. Because what's anaerobic metabolism? Correct, Munde. We're not going to enable the lungs to oxygenate because fluid's not going to carry that oxygen. Stabilize shock by restoring needed fluid and electrolytes. Yeah. Or not be able to increase the oxygen carrying capability of the blood. We can't carry oxygen in saline. During the body's attempt to compensate during hypoperfusion, there's usually an increase in the heart rate. For what reason? Well, heart beats faster. What's it do? Puts out more, right? The sympathetic nerves also stimulate the adrenal medulla gland to release epinephrine and norepinephrine. The release of the hormones takes a few minutes. However, these hormones provide a sustained effect. The primary effect of epi or norepi are a increase in heart rate and contractility, as well as vasoconstriction to increase blood pressure and perfusion. When our body gets epi introduced or it releases its norepi, epi is going to cause vasoconstriction. When we cause vasoconstriction, it increases perfusion because it increases the blood pressure. So vasoconstriction, we're taking a pipe from this big and we're going to make it this big. So when we go from this big to this big, that fluid that was sitting at about a quarter of the big pipe is now going to completely fill the smaller pipe. That's going to allow us to increase our pressure, which is going to allow us to increase perfusion. Which link of the AHA's chain of survival must occur first if the patient is to survive cardiac arrest? Early activation is key. You guys are not wrong with early CPR. I mean, you are. Early CPR does save, but we have to activate that whole chain of events in order to do anything. Which of these is most appropriate when two EMTs are performing CPR on an adult patient? At least 100 compressions per minute. 100 to 120 is what we want. Compressions to ventilations of 15 to 2. No. It's 30 to 2. Airway reassessment after every 30 compressions. No. Delivery of ventilations while compressions are being provided. No. Remember, 30 compressions, 2 breaths. 30 compressions, 2 breaths. Only time we continuously bag while we're doing CPR is if we have an advanced airway placed. Following question. Patient has a medical problem characterized by an increase of interstitial fluid in and around his alveoli. The condition would just normal oxygen and carbon dioxide exchange by creating which type of disturbance? Whatever. So if we think about it, we have an increase of fluid around the alveoli, right? So we're already going to have a decreased respiratory cycle. If this condition disrupts normal oxygenation and carbon dioxide exchange, it's going to create a gas exchange issue. If we are having an issue with oxygen and carbon dioxide, that's a gas exchange issue. Hey, Jesus. How you get this now? Ouch. The patient with an unknown medical problem is responsive to painful stimulation and breathing poorly at a rate of 8 breaths per minute. The airway is patent and the skin is warm and moist. Patient's radial pulse is strong and irregular. Breath sounds are absent over the basis of the lungs. Vitals are pulse of 84, blood pressure 256 over 120. They probably have a brain bleed. And SpO2 of 81%. The best treatment for this patient's breathing difficulty would be positive pressure ventilation. We're going to bag this patient. And if nothing else, take nothing else out of that question, they're breathing 8 times per minute. Inadequate ventilation, we breathe for them. CPAP is contraindicated because he has altered mental status. He's only responsive to pain. In order to CPAP somebody, you have to be able to maintain, they have to be able to maintain their own airway. And you really skate that line with the inadequate respirations. You know, normally CPAP with some inadequate respirations, yes, but when you have that altered level of mentation, absolutely not. They have to be able to maintain, their own airway. Well, there was too much to read in 2 freaking seconds. 40-year-old female patient's having great difficulty breathing. She's responsive to verbal stimuli and has an open airway. Respiratory rate of 40 a minute. She has an SpO2 of 88, which dropped from 9. Never mind. Just forget it. Four-year-old female patient's having great difficulty breathing. She's responsive to verbal stimuli and has an open airway. Respiratory rate is 40 times per minute. She has an SpO2 of 88%, which has dropped from 90. So we are going down that downward slope. Despite high flow O2, through a pediatric non-breather, her pulse is rapid and her skin is cool to the touch. So we're in shock. As a knowledgeable EMT, you would recognize these findings associated with which condition? Why is it respiratory failure, not respiratory distress? Yes. Failure, you can see. She has inadequate respirations. We're on high flow O2 and our SpO2 is dropping. Our respiratory system is failing. Respiratory arrest is not the case yet. We are working that way. In cardiopulmonary arrest, we're not in. Yes, correct. On scene, you find a 2-year-old male patient in significant respiratory distress. He is responsive to painful stimuli and exhibits noisy respirations through an open airway. His breathing is shallow at a rate of 44 times a minute. His pulse is rapid. Assessment of the skin shows it to be cool and diaphoretic with cyanosis of the extremities and around the mouth. What is the immediate priority for this patient? Well, first of all, that is respiratory failure as well, borderline respiratory arrest. But we're going to bag this patient. That patient absolutely in no way, shape, or form would ever get a non-breather. They're getting bagged. That again, that is not respiratory distress. That is respiratory failure. Borderline respiratory arrest is where we're heading with that. Patient who is nonverbal from a previous stroke is in severe respiratory distress. A family member states that she has multiple medical problems, including high blood pressure, diabetes, and heart failure. When assessing this patient, which sign or symptom will raise your suspicion that the patient has heart failure? I can see 2 answers on this, but more times than not, heart failure, we're going to get crackers. Although if you're not necessarily wrong if you say edema to the foot. But the shortness of breath with heart failure, we're getting it in the lungs. Heart failure without the shortness of breath is usually where we're getting the edema in the extremities. Answer the following question. When administering albuterol to a patient with shortness of breath, the EMT realizes that the therapeutic effect of this medication is achieved by our bronchioles is what our albuterol treatment's going to open. Correctamundo. So our bronchioles, think of bronchioles sound small, right? So if you can associate that albuterol is a bronchodilator, we're going to open, dilation is opening. So we're going to open our bronchioles. Thank you all for not answering decreased mucus production though. I do appreciate that. When a child starts to become hypoxic, the pulse will initially increase. Compensation. So increased heart rate is a sign of compensation. Decrease is when we are already in decompensated shock. It will change. All right. Before I start another one real quick, there is something that I'm going to go over. Somebody asked me about GCS. How many people online are having an issue with GCS? Anybody, everybody, anybody, anybody, everybody, anybody, everybody? Okay, that's fine. Anybody online? Yay, nay? Okay, I'm getting it's eh. Okay, some say they understand, some's comfortable, some say it's eh. So we're going to sum this up really, really quick, and then you send me a private message and we'll go from there. All right, uno momento, my peeps. All right. All right. So our GCS scale. So remember EVM. So every value meal is 456. Eyes are 4, verbal 5, motor 6. If our eyes spontaneously open, we get a 4. If we're closed, we get a 1. Remember, dead people get a 3. But so if somebody was to walk into this room, everybody in here has a GCS of 15. Our eyes are open, we're oriented, and we can obey commands. So if you walk into a room and someone's eyes are spontaneously open, they're slightly confused, but they can still obey your commands that are 14 because they're confused. Remember, what you'll get with your GCS scale is slightly different than this one. You get confused and then inappropriate with verbal. Remember, inappropriate is not somebody telling you go to hell or get bent. So when they give you an inappropriate response to a question you're asking. What year were you born? The sky is blue. How are you feeling? There's a safe falling in or whatever. Whatever the case may be, that is inappropriate. So, and then you get garbled. So they'll moan, groan. They're not making any words whatsoever. Motor obeys commands. Squeeze my hands, raise your arm, whatever. Localizing to pain. So when you do a sternal rub, they are sweeping you away. Withdrawal, they're pulling away from the pain. Decorticate posturing, They're protecting their core. They're bringing their arms into their core. Their toes are pointing inward. The cerebral posturing, our arms are out to our side, our toes are pointed outward, or you get no motor response. Eyes, they're either spontaneously open, they open to verbal, they open to pain, or they don't open at all. Does that help at all? Okay, still send me a message, we'll go over it. Okay, back to Kahoot. Before we start another Kahoot, anybody online, is there anything that you guys want to hit that we have not hit yet? Remember, comments, questions, concerns. You guys don't speak now, you forever have to hold your peace, like a wedding. Ugh. Ugh. Different types of seizures. Okay. I'm not mistaken, we're getting into that with this, I believe. If not, what I will do for you guys with seizures is by tomorrow morning, I will put the seizures up on Classroom with the different types and the explanations. Does that work for everybody? Do you have any more questions before we get into? Anybody in person have questions? Anything we haven't covered yet? Anything we're struggling with? For my seizure people online, does that work for you guys if I post the different types of seizures on Classroom? Yay, okay, yes. Yes, yes, yes. You guys are so lovely. I love all of you. Okay, let's try to get through this one. I don't know if we will, but we're going to try. If you guys want to leave at 10, that is up to you. I can't make you stay. If you want to stay and finish this, we will. You guys want to stay and go over anything else, we will. Cowboys are freaking losing anyway, or winning anyway, and I need them to lose then win. Don't get into sports betting. I didn't bet it that way. I didn't bet it that way. Whew, 18-0. But I need Lamb to get 51 more yards, 51 and a half more yards. 2, 4, 6, 8, 10, 11. I need 2 more people. And I also need Lamb and Ezekiel Elliott to score a touchdown to get $1,400. Well, one person. Anybody. 2, 4, 6. I will throw something at you. I swear to God. All right. Going once, going twice, going 3 times, and sold. Oh, you're gonna get a computer for any second. When assessing a patient's pulse, you note that didn't we just do this? Okay, guess what? Those don't have the right answers on it anyway. All arteries have lower pressure than veins, carry oxygen-rich blood, are located in the torso of the body, or carry blood away from the heart. Ooh. Arteries carry blood away from the heart, veins carry blood to the heart. When the electrical impulse leaves the SA node and starts to travel down the conductive pathway, what happens mechanically? Cardiology, yay. Arterial contraction. Honestly, that's either know it, don't know it. It's cardiology is going to be one of these things that you guys are going to have to study. Do these cahoots though, they will help. But when the electrical impulse, think about it. When the electrical impulse leaves the SA node, what's the heart going to do? So if you think of it, the SA node sits up. When it sends that electrical impulse down, it's going to cause those atrials to contract, which is going to start the cycle. Primary pacemaker site of the heart is, please, for the love of God, get this right. Please, I beg it of thee. So the SA node is the main. The SA node is what starts the whole process. The SA node fails, you got a damn problem. Well, there you go. Like Josh just said, if this will help you guys, if you think normal sinus rhythm, so the heart is normally doing its job, sinus atrial node, normal sinus. Make sense? Some of us still look lost. On an ECG, the QRS represents contraction of the ventricles. So if you, this doesn't really apply to you guys, never mind. But your QRS, when it shows up and it goes, it has a slight downward, upward, downward, upward. That is your ventricles contracting. Patient has pulmonary hypertension, which has increased the resistance in the pulmonary blood vessels in response. What will most likely occur over a long period of time? You think about it, pulmonary hypertension is going to increase the resistance. So pulmonary hypertension, so our blood has to go into the lungs, pick up the oxygen. The heart has to pump harder to push past that resistance in the heart. So the right side of the heart is what sends the blood to the lungs. With that being said, the right side now has to work harder. We're more than likely going to get, right-sided failure or weakening of the right side of the heart. Honestly, no, because the heart has its divisions of what does what. I mean, the left side ends up picking up some, but not. All right. If a clot occludes the blood flow through the coronary artery, what will be the detrimental effect? We have a clot in that artery. The blood and oxygen that's needed to get to the muscles, which of the ventricles, is decreased. So if you think about it, what a clot does what? It clots, right? It's a roadblock, so to speak. Think of it like a dam. So that clot goes up, you're getting restricted blood flow and oxygenation to the muscles of the ventricle, so it's going to be decreased. Eventually this could be caused. No. No. We'll examine this in a second. Patients called 911 for chest pain that describes as tearing and radiating between his shoulders. Oh, we got a. Hey. His airway is patent, breathing accelerated but adequate. Radial pulses are intact. Your partner reports the following vital signs: pulse 120, respirations 22, blood pressure 88/64, SpO2 is 96%. At this time, you should recheck the blood pressure in the other arm. Why? If you stop and think about it, when we have a AAA, what are our signs of a AAA? Pain, tearing sensation between the shoulder blades, right? With AAAs, when you're starting to get the effect of them, you're going to get a different blood pressure in each arm. I know we went over that. So let's say we get that 88 over whatever in the right arm, our left arm is definitely going to be different. So it's putting those pieces together. So, when you get that tearing pain that radiates between his shoulders, that is with chest pain. That's the first thing you need to go to is AAA. Aortic abdominal aneurysm. Usually they say 100, but 120 usually. You suspect that a patient with a history of COPD has right ventricular failure. In your assessment, which of the findings would reinforce this? Remember, where does the right side get the blood from? Edema of the feet. Left-sided heart failure puts it back into the lungs. That's when you get your crackles. Because remember, what is the right side of the heart getting? Your right atrium is getting the deoxygenated blood from the body to go from the right atrium to the right ventricle, out the right ventricle to the lungs to pick up oxygen. As it picks up oxygen, it goes back into the left atrium to go into the left ventricle. From the left ventricle out to the body, it flows through the body, delivering its oxygen, and then it takes the deoxygenated blood back to the right atrium. So if we have right-sided failure, that blood's going to go back where? Where it came from. Gravity. Gravity's a bitch. You're transporting a patient with chest pain to a hospital emergency department. In regard to possible fibrinolytic therapy, what should you relay during your hospital report as a possible relative contraindication to this therapy? The use of anticoagulant medications. Patient takes blood thinner, they may not be a good candidate for fibrinolytics. One of the things that we have to ask our patient, and it's one of the things that we always relay to the hospital. Do you take blood thinners? Yes. Okay, what do you take? And we tell the hospital. Which of these patients would be most eligible to receive fibrinolytic therapy for a stroke if no other contraindications are found? You want me to tell you why this answer is right? Well, A, hemorrhagic stroke does not get fibrolytics. We're not gonna, bust the clot that's trying to, we're gonna want that to clot. But we don't know what time it is, right? So it could be 6:01 PM. They're within that window. An 81-year-old male who awoke with stroke-like symptoms after an 8-hour sleep. Depending on where you're at, he may still be in the window or he may be out. 37-year-old female diagnosed in the ER with a hemorrhagic stroke 2 hours after onset is incorrect. Fibrolytics, so clot buster, going to thin the blood, right? It's going to get the blood around the clot. Hemorrhagic, do we really want to give them fibrolytics? No. A 62-year-old whose stroke symptoms started at 8 AM and disappeared 30 minutes later. No, because that's a TIA, they don't need it. TIAs are just usually a precursor that you may have another stroke down the road. As a general rule, a post-ictal patient should be placed on the stretcher and transported in what position? Lateral recumbent. We don't want to put them supine in case they vomit. Then they're going to aspirate. Semi-flowers, they're sitting up, they're partially upright, going around your prone. You, good God, please, the love of Jesus, don't ever put a patient face down. Lateral recumbent, so left lateral recumbent. So we're going to put them in the recovery position. Why? If they puke, they're puking on their side. Also, they're not puking into your cabins on the side. Full plus. 20-year-old patient is unresponsive with snoring respirations. She's in a public restroom and has no family or friends with her. After addressing the airway, breathing, and circulation, you begin the secondary assessment. Which of these signs most likely indicate the patient experienced a seizure? Please get this right. Constricted pupils are an overdose. Snoring respirations, they're unresponsive. So that just tells you they're don't have a patent airway. Altered mental status, they're unresponsive. Urinary incontinence. You have a seizure, you most of the time are going to be incontinent of your bladder, if not bladder and bowel. Let's just remembering that. With normal metabolism, what happens after a healthy patient ingests food? The insulin in the blood's going to rise. It's going to have to help. It's going to help regulate the sugar. You got to remember, when we eat, our body takes in carbohydrates and sugars, which makes your BGL increase. A normal person that's healthy, their body auto regulates that. So as you're eating and as the food's digesting and all of the parts of the sugars, the carbs, and all that are getting broken down into the body naturally releases the insulin to help counteract that, so our blood sugars stay within normal ranges. Glucose levels in the body drop quickly. That's absolutely incorrect. The liver has nothing to do with glucose. That's not where the glucose is stored. Excess glucose is released in the urine. No. An unresponsive patient presents with a blood sugar of 30. What is the major threat to this patient's well-being? Brain damage. Why? Recommended. After assisting a patient with the use of an epi auto injector, you note the patient's blood pressure is improved. As a knowledgeable EMT, you realize that this effect occurred to the epinephrine's ability to. Remember, epi, when it is introduced into the body, causes vasoconstriction. So we constrict our blood vessels, which causes an increase in blood pressure. You've been called for a 13-year-old boy who was caught sniffing glue by his parents. The boy is lethargic and confused and complains of burning in his mouth and his nose. No shit, dumbass. And has nausea and vomiting. Based on the clinical presentation and the mechanism of illness, how has this poison affected the patient's brain? Crossing from the lungs into the bloodstream and then circulating to the brain. So when we inhale something, we're inhaling it through our nose or through our mouth, and it's getting to our lungs. What passes through our lungs to pick up oxygen? Blood. As our blood goes through, it goes through the body. Where does blood eventually end up? The brain. Patient is agitated and hyperactive with dilated pupils and tachypnea, most likely ingested. Methadone, no. Heroin, absolutely not. Heroin's a downer. Hallucinogens, possibly, but they're usually not. Hallucinogens, you're usually getting the skittish type behavior. Yeah, you can still get the dilated pupils from them sometimes. Tachypnea, so the breathing fast, you may not get those with the hallucinogens. But crack cocaine, being the stimulant, is going to cause increased blood pressure, increased heart rate, increased respiratory rate. It's going to cause the dilated pupils. It's going to cause you to be super skittish. And it's just like, think about somebody, think of someone who gets like 5 shots of espresso in their coffee. It's an upper. Increased heart rate, increased blood pressure. You're breathing faster. Oh my God, you're going 90 million miles a minute. You can't keep track of it. Blah, blah, blah. They're pinging off the walls. That's another example of it. All right. So it's 9:58. If you guys want to do another Kahoot, I will. If you don't want to, you don't have to. It's up to you guys. You do have the ability to do them at home. So, does anybody have any questions before you depart? Or if there's people who want to go through another Kahoot, we can. You just have to say so. You guys are the boss here. We can. Yeah. Anybody that wants to stay and do one, go for it. Same with the people online. What did we just do? 4, right? All right. If you guys online, when can you start test 9? Test 9 your take home one. I think you guys should be able to get into it tomorrow. I will ask Jamie for sure if it's not open by tomorrow. But if you guys online want to stay and go through this next Kahoot, you can. If you don't, you do not have to stay. It's completely up to you. What's that?
Exam.
Oh, exam 9 is available. So there's that. So, but anybody that wants to stay, stay. Anybody that doesn't, you don't have to. It's not going to be held against you. Hmm. All right, hang on, we'll wait for her to come back. All right, guys, we're just waiting on one person. All right, did you get in then? All right, everybody in? Yeah. All right. All right. That's fine. All right. The young man fell down a flight of stairs and is now restless and confused. His airway is open and he's breathing adequately at 18 times per minute. Has a radial pulse of 102, a blood pressure 96/78, and his skin is cool and diaphoretic. Your next action would be to so a young man fell down the flight of stairs and is now restless and confused. His airway is open and he's breathing adequately 18 times a minute. Radial pulse 102. Okay, so with him falling down stairs, I definitely agree with the cervical collar. I don't necessarily agree with the longboard though. There's not exact indication of it at this time. That's kind of what takes that one out of it for me. Definitely does not need a nasal airway. Breathing seems to be fine. So I'm not quite sure why we're doing the oxygen, but yeah, for you guys, it's right. Sorry, I have to keep reminding myself that's what we do. "24-year-old male patient was riding his ATV through the woods and impaled himself on a dead tree branch. 1-inch diameter branch went through his mouth and out his right cheek before breaking from the tree. On your arrival, the patient is bleeding heavily into his mouth and struggling to breathe unless he's leaning forward to gain control of the bleeding and thereby his airway. You should. When do we remove something? When do we? So with this guy, on your arrival, your patient's bleeding heavily into his mouth and struggling to breathe unless he's leaning forward. To gain control of the bleeding and thereby his airway. So the only way you're going to gain control of that airway and be able to control that bleeding is if we remove that impaled object. We can control bleeding or control the bleeding, suction the airway, and we can better managing that way. Nasal airway is not going to help us here. If we pack his mouth full of gauze and tell him to breathe through his nose, we're creating further airway obstruction. And no. Okay. Which assessment finding would best indicate that a patient has suffered a full thickness burn to his leg? Dry skin with little pain, and here's why. When we get a full thickness burn, we burn all the way through our nerve endings and everything. So we're not gonna have pain at the site of the burn. We'll actually have pain out and around the burn. But you're gonna get that real dry, charred skin with very little pain at the site. Peace out, people. Female patient is 36 weeks pregnant with twins. Tripped in a parking lot, hitting her head, her wrist, and her abdomen. She's alert and oriented, complains of a headache and abdominal pain and wrist pain. Now I'm gonna read that when we're done. Now I'm gonna sign out of it.